other in a fight. But we really need to go to the basic. I did not take anything which was beyond what is cancer, what causes it, how do you prevent it, how do you take care of it. The first thing, in simple layman language, what is cancer? Uh, you're sitting right next to Nikhil, and if you keep poking Nikhil 15 times, 20 times, so at one, however nice and calm and cool Nikhil is, he'll turn around and slap you. That is what is cancer. You keep troubling cells of your body in different ways. At one, loses its temper, changes its course, and explodes. In layman terms, this is what we are able to tell our patients if they ask us कि ये कैंसर क्या होता है, ये कैंसर ये होता है. So anything we damage to our body in a way which is not acceptable to the body, after a certain amount of time it explodes. Lot of cancers are there, different types from top to bottom, from head to toe to brain to bone to blood. And yes, this is also something which we all know. Leading figure is Mr. Sharad Pawar, unbeatable kind of person in amounts of cancer. So all of these people have gone through cancer. So cancer is basically like COVID. It does not see race, religion, affordability, your money. उसके लिए फर्क नहीं पड़ता है. जिसको होना है उसको होना है, and what the person has to go through has to go through. So it doesn't make a difference how rich or poor you are. But before smoking, and I think I'm just audible anyhow. So smoking and alcohol is the first thing we talk about in cancer. But how many of us do know that obesity itself can cause cancer? Do you know obesity can cause cancer? Which cancers can obesity cause? So basically obesity मतलब हमारे ऐसे लोग. I keep reading about obesity and cancer because I know कि थोड़ा high risk रहेगा. सर नहीं है, डॉक्टर देशपांडे नहीं, तो हम दोनों का high risk रहता. So what is the place? Why does obesity come in our public? हम लोग क्यों हैं इतने खाते पीते घर के लोग? क्योंकि it starts from childhood. हमारे बच्चों के advertisements are on fast foods. The children are more on the laptops and the mobiles, less in the ground, try to climb trees. In fact, अगर कोई बच्चा पेड़ चढ़ता है तो पेरेंट्स बोलते हैं गिर जाएगा. हम लोग जब छोटे थे तो पेरेंट्स बोलते थे जा जा चढ़, देखते कितना चढ़ता है, कब गिरेगा. So that is a difference of more fear for us and more screen time for the kids. We have increased frequency of eating away from home. We have things which popularize sugar sweetened beverages. We have larger portion size, a sedentary lifestyle like you said. So it starts from when they are 3 or 2 or 4. That I know from personal experience, and I'm sure all of you, that the more you try to get them away, the more they are attracted towards that lifestyle, leading to obesity. Does obesity really cause cancer? Can we say an obese person is a high risk for cancer? We have spoken about smoking, alcohol, sedentary lifestyle. But कोई मोटा है तो क्या उसको कैंसर का रिस्क है? Apart from other things like gallstones, cardiac diseases, high blood pressure, arthritis, yes, cancer is very much a part and parcel of obesity. Obesity is the first lifestyle change we need to do. What cancers can obesity cause? It can they also share the hookah. So other than that cancer, they also share HIV, HBsAg, and so on and so forth, because that is also very easily spread in that sharing that one hookah. It's a closed room, so passive smoking is a lot. So duration is more, amount of smoke is taken is more, and you also share the hookah, thinking that it's cool, but you share other diseases too.
It is increasing, but in Egypt it is stopped.
Yeah, anyone is smarter than we always are one step behind becoming smart.
अपने सिगरेट की जगह हुक्का चल रहा है.
यहाँ बहुत बढ़ रहा है, and that is why यहाँ slide नहीं है, but I thought this, okay, everyone knows. We have smoked tobacco, we have smokeless tobacco. It causes lot of things like strained teeth, bad breath, cardiac diseases के अलावा lung cancer, oral cancer, food pipe cancer, all cancers are related with smoking. But hookah is something which we have to somehow stop our kids from doing that. It's already a fear factor in this. आगे जाके मालूम नहीं क्या होगा.
Only in breast cancer.
In
breast cancer,
yeah.
highest incidence.
Yes.
Smoking. Where female women more smoke more.
Nowadays they are
the latest
data
is
also changing.
World WHO data
is hookah.
Yes.
Tobacco, smoke and smokeless, cigarette smoking, consumption of all these nice things. But everyone talks cigarette नहीं पीना चाहिए. Cigarette के constituents क्या रहते हैं? What do you think makes a cigarette? Other than the nicotine tar, we all talk. अरे nicotine होता है, उसमें ये होता है. और क्या क्या होता है cigarette में? Cigarette has sewer gas, sewer का, gutter का gas. Cigarette has battery का liquid cadmium. Cigarette has arsenic. Cigarette has tar. Cigarette has toilet cleaner, the constituents of toilet cleaner, and 176 such more things. So whenever we smoke a cigarette, I don't. Whoever of you smokes a cigarette, don't think only about the nicotine. Think also about the toilet cleaner. That's in your mouth and in your lungs. So that should be a thing which should be told that okay, stop, stop. We give a concession to the alcohol. We always say, we can't say अभी तुम दारू भी नहीं पियो, सिगरेट भी नहीं पियो, नॉन वेज भी मत खाओ, रेड मीट भी मत खाओ, तो तुम जिंदा क्यों रहो? ऐसे लोग क्वेश्चन पूछते हैं हमको. Alcohol in moderation will not cause major diseases. In moderation is a different definition to understand that.
पर वो moderation कभी
कोई करता नहीं. Exactly. तो वो different definition कोई करता नहीं, but जो करते हैं वो हम ये बोल सकते हैं in moderation will allow, but should not be taken as a thing कि हम दारू पी सकते हैं. What are the other risk factors? Hormonal and reproductive factors which are important for breast, cervical and ovarian cancers. इसमें lifestyle कैसे आता है? So whenever there is a breast cancer topic, I feel like putting my photo there, because someone who is above 40, unmarried, no child, not breastfed, what risk factors? Stress, obesity, lack of physical exercise. I am falling in all the risk factors for breast cancer.
Smoking, everything else.
Smoking नहीं है.
बॉम्बे का AQI और स्मोकिंग.
It is hookah. Same thing.
But I don't take hookah.
वैसे भी स्मोकिंग है ना, आपके अगल बगल के लोग
देखो सर, ये अगल बगल में आ गए हैं.
AQI है, बॉम्बे का AQI है.
Bobby का AQI. Other than that, obesity, diet, lack of physical activity, air pollution, I'll talk about all these occupations, like dye factories, metal industry workers, asbestos. I went to a talk one day at Chhatrapati Shivaji University at beyond Panvel, and I told them, see, you're sitting right next to a construction
stalwarts with us here, and I've tried to keep it to the minimum considering the amount of time we are spending.
I can introduce myself.
Yeah, I think, okay, he'll take some of that. Yeah, sure, sir, welcome. Yeah, we're looking forward to the presentation.
So morning everyone. It's great that everyone is present here on a Sunday morning. And continuing with the theme, what Dr. Priya has already started, I'm going to share with you about diagnosis of oral cancer and pre-cancer. My name is Dr. Sagar Vaishampayan. I'm a maxillofacial surgeon trained from Government Dental College and Hospital, Mumbai, and later did my fellowship in head neck cancer surgery at Tata Memorial Hospital. So I've been treating oral cancer patients for past 13-14 years, and I'll be talking to you about oral cancer and pre-cancer. So going ahead, sadly, India is oral cancer capital of the world. Majority of our oral cancer in Indian men present at an advanced stage where they require extensive surgery followed by adjuvant treatment in the form of chemotherapy and radiation, and it is draining them completely financially, physically, in every possible way. And at the end of this treatment, prognosis, 5-year survival is extremely dismal in percentage of 30 to 40%. So the most important thing is early detection. If you diagnose the oral cancer at stage 1, stage 2, and treat it adequately, the cure rates improve significantly, and they are more than 70 to 90%. So this is how oral cancer starts: an innocuous looking non-healing ulcer, non-painful on the lateral border of tongue. This is a slightly advanced lesion, again non-painful, in gingivobuccal complex area where patients habitually keep the quid because smokeless tobacco is commonly used in India. And this is how they present: a stage 4 cancer, advanced operable oral cancer, and sometimes it can become inoperable, and we can't offer any treatment except for palliation. So this is a typical oral cancer, what presents to Indian doctors. This is a stage 4 squamous cell carcinoma of lower gingivobuccal sulcus. Once we get this patient, first thing what we do is do a biopsy to prove the diagnosis, and then we map the disease. The simple commonest examination what we do is a CT scan with contrast, oral cavity, neck, and a CT chest plane. Or if we have access for such advanced lesions, we do a PET CT scan to map the disease. Patient requires adequate tumor clearance with 2 centimeter margins as well as neck dissection and extensive reconstruction. In this patient, we have done a fibula flap. And after this, within 6 weeks, we have to start with adjuvant chemo radiation, and this is the end result. Despite all this, the prognosis remains really bad. Less than half of patients see 5th year after treatment. So we know what causes oral cancer. Dr. Priya has already highlighted tobacco, whether it is smoked in the form of BD, cigarette, hookah, or smokeless tobacco taken with lime, that is a commonest habit, mishri, that is burnt tobacco. There are all fancy names, kharra, mawa, and very important is not to forget about areca nut, supari. A simple supari is a grade 1 human carcinogen, proven to be grade 1 human carcinogen since 1984. And alcohol is more implicated in tongue and floor of mouth cancer. So what is unique about oral squamous cell carcinoma is majority of these lesions present with a pre-cancer or morphologically altered oral mucosa, and they progress into oral cancer. So that gives us a window of opportunity. Normal oral mucosa, abused by chronic use of tobacco, alcohol, and supari, changes its characters, converts into oral dysplasia, and finally invasive squamous cell carcinoma. The molecular pathway also is well established, and we know for sure that there are various markers which keep expressing from transition of normal mucosa to moderate and severe dysplasia and finally squamous cell carcinoma. So what is this precancer? Precancer is scientifically termed as oral potentially malignant disorders. So any oral mucosal abnormality that is associated with statistically increased risk of developing cancer is called as OPMDs, or oral potentially malignant disorders. Why the term potentially malignant is because not all these lesions progress to oral cancer, and it is a disorder because there is increased susceptibility to develop oral squamous cell carcinoma because of exposure to the environmental factors like tobacco, alcohol use, and very rarely endogenous factors like certain syndromes like Fanconi's anemia and Plummer-Vinson syndrome. So there is a huge classification of these. I'll be covering the important ones. So the most important one is leukoplakia. You can't miss leukoplakia. Leukoplakia is a non-scrapable white patch attributed exclusively to the use of tobacco. So this is a very small, innocuous looking white patch, homogeneous leukoplakia. This is extensive leukoplakia of the tongue and the floor of the mouth. This is what we call as tobacco pouch leukoplakia or tobacco pouch keratosis, where habitually patient keeps tobacco quid in this area, and this is a homogeneous leukoplakia. So the problematic ones are the heterogeneous leukoplakia. They are sub-classified as speckled leukoplakia, where there is red and white patch, hypertrophic or proliferative leukoplakia, and a nodular leukoplakia. So these are the leukoplakias we should be getting well versed with and identify them as high-risk leukoplakias. So once you identify leukoplakia, the heterogeneous variety of leukoplakia has a very notorious malignant transformation rate, reported anywhere from 15 to about 40%. So once you identify leukoplakia, what to do next? So the first and foremost step is counsel the patient for immediate habit cessation and identify the risk factor and habit cessation. The next thing what you are supposed to do is not just identify it on clinical features. We must always do a biopsy. Biopsy will help document the disease and identify degree of dysplasia. So once we identify what type of leukoplakia it is, a homogeneous leukoplakia, small size, no dysplasia in the biopsy, patient has quit the habit, we may be able to keep that patient under close follow-up, like 2-monthly, 3-monthly follow-up. Where to intervene surgically? All heterogeneous leukoplakia with moderate to severe dysplasia, tongue as a subsite, and if the patient is continuing with habit, these are high-risk leukoplakia which you shouldn't observe. Entertain them surgically, remove it with good margin, send it for histopathology, make sure that they do not contain a focus of squamous cell carcinoma. Moving ahead, this is a very notorious thing, very difficult to handle. This is proliferative varicose leukoplakia, classically seen in elderly patients. Sometimes patients do not have any exposure to tobacco or alcohol for that matter. There is widespread involvement of oral mucosa and various oral cavity subsites, tongue, buccal mucosa, cheek, and in this area sometimes you get malignant transformation. So malignant transformation rate for proliferative oral leukoplakia is in excess of 50 to 70%. It is extremely notorious, very difficult candidate to treat. So you have to keep the patient under close observation, say monthly or 2-monthly observation. Do repeated biopsy, and whenever there is evidence of invasive squamous cell carcinoma, you have to treat it adequately. Such. Moving ahead, oral erythroplakia. Again, you can't miss oral erythroplakia. It is a red velvet patch which is non-scrapable and exclusively attributed to use of alcohol, tobacco. So these lesions are never to be observed because about 50% of erythroplakia contain carcinoma in situ or invasive squamous cell carcinoma. So then the only treatment that remains is excision with wide surgical margins and histopathology. Oral submucous fibrosis. Oral submucous fibrosis is very unique to India and Indian subcontinent because of use of areca nut or supari. So unlike tobacco and alcohol, which are already have a social taboo, supari doesn't seem to enjoy that taboo, and lot of patients do have areca nut, purely areca nut habit, and they tend to get oral submucous fibrosis, which is again a notorious disorder. It is a chronic insidious disorder causing progressive fibrosis of oral mucosa and a gradual atrophy of muscles that move the lower jaw and causes prolonged trismus. Once the disease sets in, there is no way to reverse those changes. All you can do is treat these patients surgically to improve mouth opening if they reach to a stage where they cannot take care of their oral hygiene and they can't eat. So only option is available in terms of surgical intervention just to improve mouth opening and not to cure the disease. The malignant transformation rate of oral submucous fibrosis is in excess of 50%. I included oral lichen planus because it is commonly seen by a lot of physicians, patients coming with repeated oral ulcers. This is an immunologically mediated mucocutaneous disorder. Primary site of involvement is oral cavity, but it is not uncommon to have dermal involvement. Oral lichen planus is characteristic that it has a lesion which shows interlacing white lines we call as Vicam stripe. There are multiple presentations of oral lichen planus. This is an annular variety, this is atrophic variety, this is erosive lichen planus, and this is hypertrophic variety. All of them, they have these Vicam striae, the white interlacing lines surrounding the lesions. Usually presentation is multicentric. You have multiple subsites of oral cavity presenting different forms of oral lichen planus at a single time. If you do biopsy these lesions, dysplasia is rarely found and all you see is destruction of basal cell layer. Don't scare your patients that this is a bad disease. Specifically if patient is not having any habits like tobacco, alcohol or areca nut, because average malignant transformation rate for oral lichen planus is very low, about 1%. Oral lichenoid lesion, these are commonly seen in patients who have various medication for diabetes and hypertension, and sometimes patients with certain dental restoration, they tend to present with these lesions. They look very similar to that of oral lichen planus, but most of the time oral lichen planus has a universal appearance. It is present at multiple sites in the oral cavity. Oral lichenoid lesions are present at one single area in the oral cavity, and if you biopsy these lesions, you will find some sort of dysplasia, and malignant transformation rate is higher than oral lichen planus. So it is important for all of us to be well versed with what pre-cancer looks like. So does it make a difference if we catch the cancer early? Yes, it does. Early cancer, if you catch it early, it requires single modality treatment in the form of surgery. Surgery is for a T1, T2 cancer is not very extensive. You don't require extensive resection. You don't require extensive reconstruction. The form and aesthetics is very well maintained. There is reduced morbidity and improved survival for stage 1 and stage 2 cancer in excess of 70%. Is early detection possible? Regardless of what specialty we are practicing, oral cavity is most easily accessible to all doctors. All you require is a good illumination, and you require a tongue blade at the most. Make sure that you always target high risk group. Patients who chew tobacco, smoke tobacco, have a history of alcohol. So finding lesions in them is easier. A direct visual examination by a trained eye does the trick. What evidence we have? We have the largest trial coming from Trivandrum done by Shankar Narayanan. It is the most quoted study in this subject. It was published in Lancet in 2005, where they trained healthcare workers in Kerala just with images of oral cancer and pre-cancer. They went door to door, find out the incidence of pre-cancer in general population, specifically high risk group, and it reduced cancer mortality and increased the rate of cancer detection at early stage in a significant way. So early detection is very much possible. If health workers can do it, every doctor can easily do it. Do we require any adjunct to diagnose oral cancer and pre-cancer? So a plethora of agents available in the market. and believe me, the names are difficult to remember. They are expensive, and whether we actually need it, we have a randomized meta-analysis, and it tells you, it is published in 2015 Cochrane analysis. It says that all you need is good illumination, trained eye, and biopsy as a gold standard to diagnose oral dysplasia and early oral cancer. You don't require these fancy gadgets. Biopsy is still the gold standard. All you need is basic armamentarium, local anesthetics, biopsy from an area where you take the dysplastic tissue along with a healthy normal tissue with adequate thickness and send it across to the pathologist, and you will get the diagnosis. That is the most simplest thing. So to conclude, oral squamous cell carcinoma is a significant health risk, especially in India. Early detection and early treatment improve survival and quality of life. Identifying high risk factors like use of tobacco, supari, alcohol makes a practitioner more conducive towards keeping these patients under surveillance. Getting awareness of oral pre-cancer and keeping these patients under long follow-up is a must, and incisional biopsy, histopathology and timely referral will improve survival outcomes in oral squamous cell carcinoma. Thank you.
Hello. Yeah. Thank you, Sagar sir. I just had, anyone has any questions for Sagar sir, we can take them up. Or Priya madam also. Yeah.
So,
Yeah.
जितने भी ट्रक ड्राइवर्स या जो भी ड्राइवर्स
Ma'am, may I please request everyone to use the mic because we are on Facebook Live. Everybody will be able to benefit from this.
सो जितने भी ड्राइवर्स हैं वो लोग पूरे समय मुंह में कुछ रखे रहते हैं, और उनसे पूछो कि आप लोग ये क्यों खाते हैं, तो वो कहते हैं कि हम वी आर नाइट ड्राइवर्स, हमको जगना रहता है, हम सो ना जाए तो मुंह में कुछ रखकर चबाते रहते हैं. वो टोबैको होता है, गुटखा होता है, सुपारी होता है, इसके लिए क्या कर सकते हैं?
Madam, I think it is just an excuse. Like,
No, abroad is done. Chewing gum. Abroad they do chewing gum.
Replace it with the chewing gum.
Chewing gum. They're using it abroad. Because
So I
they don't
think-
eat, they were smoking on driving also, but that has been now banned. You can't do that, you'll be punished. So now they use chewing gum.
नहीं, पर कंट्री ऐसा क्यों नहीं करती कि पान, सुपारी, गुटखा, तम्बाकू इसका प्रोडक्शन ही बंद कर दे?
अरे
क्योंकि
You know that, pardon my interference,
yes.
I have a very good friend who was Minister of Health, Shatrughan Sinha. He brought in, he convinced Atal Bihari Vajpayee that we should stop tobacco and all these things. So Atal Bihari Vajpayee told him that, see, you must understand, there are so many tobacco people who are, the things are leaves, their income comes from that. So ultimately, Shatrughan Sinha went back to the finance department and found out at that time the amount of my earning from these people was 17,000 crores. He went to the health department again. He told people to take out the expenditure they're doing of treating official, mind that unofficial is not mentioned. 31,000 crores was the money spent on treatment of these people. And that was the reason he could convince Atal Bihari Vajpayee that the gutka and pouches were banned. Unfortunately, the High Courts and the Supreme Court restarted, and that's the history. So unfortunately, the society has to be alert, and I don't think that will be possible in this part of the world. So,
Mint,
There are few more questions, sir.
tablets. Many people use a mint. Yes, always.
you're right, absolutely right.
So
Anything which lasts inside to give you something different feeling, so that they are awake. So abroad, I don't know what kind of chewing gum they do, I don't know, I'm not aware. But I was reading somewhere in Islam said that even if you are smoking or you are drunk, that is of course fine. But you can't be chewing anything, and you can't do anything, any smoking, anything, and any tobacco project. And that's why they came out with that chewing gum.
So I think in India, I don't know, I'll actually confirm with Sagar, people eat soft khate hain. So I don't, I mean,
There is no.
so kidney में सर मैं ये बता सकती हूँ कि रात को अगर लेट नाइट ड्राइव कर रहे हो तो sometimes you are drowsy and that time putting something in your mouth just to keep yourself awake helps.
Right.
So in India we can actually promote salt because that is.
अब सौंफ तो 2 मिनट में खत्म हो जाता है ना.
नहीं ना वो चबाते हो.
Until my patient use दालचीनी. दालचीनी.
Yeah,
Actually, all of us work a lot. I don't need an excuse to work a late night.
Point well taken.
So ultimately, yes.
No, but what Priya mentions, it is right. See, those people are,
Yeah.
whole day they are busy. They hardly have time to sleep, and they do this for money. And mind when they are driving heavy vehicles, they need something that can their what you call as conductor or whatever nearby helper.
Yes.
They are also having the same thing. So if somebody is sleeping by the side of you, you want to sleep, and that is natural. So that was the one that is right what she mentioned, and you mentioned that they are putting something inside. So the good idea is to get that chewing gum imported from India and that will be cheaper provided to see that that thing is stored already.
Okay, Saleh.
Yes.
The denture is not fitting properly.
Yes.
It is a chronic irritation and friction.
Yes.
He is fitting a denture. Can cause the cancer.
Absolutely. And it is absolutely.
It's like a poking example.
Anything that is ill-fitting, like ill-fitting nature, and there are more and more reports.
Very common.
Yes, it is common. It is common. Yes.
There are some more questions here.
Even if the wisdom tooth is very oddly placed, they can also create cancer. And because there is a occlusion, that cheek comes in between the cheek. So that can also.
Yeah. So if we look at population at large and the amount of disease load what we get, the commonest factors we know for is tobacco, alcohol, areca nut. Okay, all one anecdotal factor like chronic trauma, yes, it is present, and sometimes in 1 in 100, sometimes you cannot attribute to any particular cause. But these are a rarity. What we must target is sensitize our own patients to avoid use of cancer-causing substances.
And sir, I just wanted to add one more thing. And it's very ironical. Even in Filmfare and all, most of the people who are doing pan masala and all, they are branding in some Goa or some other Mava or some other name.
Difficult to break the pattern and ask the government not to get it done because that has got conditioned to our society.
Sir, but silver filling in the reverse. You put a silver and gold filling in the. It is a
Very rare. Like it is,
One more
can't
question.
attribute particularly.
Actually, cancer can be detected in 3rd or 4th stage, but why is it not possible to detect in early stages? Actually, when it is detected, we see it means it has reached to the 3rd and 4th stage finally. So for that, what can be done?
Wait here for a
So basically what happens is early stages, the early cancer may not be symptomatic. These patients, they are not visiting dentists all the time because awareness of getting oral health is not still that great in India. But what my point of telling this in a general meet is because a person must be going to a gynecologist or going to a physician. All you need to do is when you are taking the history, if you are able to find that a patient has a high risk habit, spend an additional minute to examine the oral cavity because it is easily possible to examine. All you need is just good illumination.
Whatever you tell,
That's it.
care provided go door to door and see the oral cavity.
Yes.
You told that, no?
Yeah. So yeah, that will take more budget. The thing what one should do is identify people who are chronic abusers of tobacco, alcohol. They must be visiting some or other doctor.
It's very easy to add this oral checkup in your
In a general examination.
checkup, हाँ.
Yes, in a general
जो
examination.
yearly करते हैं ना सब लोग.
बिल्कुल.
So you should add
Annual checkup.
compulsory in that.
Exactly.
That will be.
point taken.
I'll just add a couple of things. Part of my talk was also oral cancer, but he solved a lot of my issues. So sitting, deleting the slide, which is good for me. I can talk something else. We all talked about checkups and all that. How many of us have gone to a dentist without a problem? That's the problem. We ourselves, okay, there's one there. I do it very often.
He is a dentist. He's going to do that.
No, not going, getting yourself checked up without having any dental problems. And that's the problem. It's in our mindset, and I always give this more to lay public. How many of y'all own a car or a vehicle or something which is more than about 5 lakh rupees? Most of us. Regularly that maintenance call comes from the company, you send the car for servicing and all. Just because this body you've got free of charge, we don't value it. And I think that is the crux of it. And the other question, I didn't see the person who raised the question about checkups. The whole program of today's is for that. Yes. Is to make all of you aware of the importance of cancer, the early detection, so that whenever you see a patient, as has been rightly pointed out, just open the mouth, put a torch over there and see whether there is anything you feel untoward. You might not be experienced about it, but if you obviously will make out there's something odd over here, send it to your dental colleague. Please don't rush the patient to a cancer because he's not going to go anywhere. He gets scared, he will not go. Send to a colleague or somebody whom you know who deals with this, not as a cancer specialist. Let him or her take that decision of whether it requires a further investigation, and accordingly you follow it. I think this is the whole program is meant for that, to make you all aware of how to increase the early detection of these cancers.
Sir, one more question. Which are the saliva and serum biomarkers?
I think it's part of my topic again. I think tumor markers, please be very, very careful. It's become a fad today in a health checkup to do tumor markers. Personally, you ask me, I think it has no meaning. It's only got meaning when there is a proven cancer and in which you have a raised marker. Again, remember, not all tumors or all cancers give raised markers in spite of being cancers. But some of them do, and that is the complexity of this whole thing, which is very difficult to unfathom as of now. But I'll talk about it in my lecture, which I think I will elaborate it on that.
Thank you. Thank you. This is it's a good thing to hear more questions. I had one, but I'm going to take it in the end to Sagar sir because we have to proceed further. All right. But yeah, thank you, Sagar sir. And I think the biggest takeaway as a practitioner, what I believe from this session would be spend that one additional minute if you find something that is concerning, and that is where we all come from, a place of awareness and a place of having empathy for our patients who don't have enough awareness about how these things can harm them. So I think exactly the early detection and spending that one extra minute in our OPDs is what I would personally take away from the session that Dr. Sagar had. Next up, we have the privilege to have amongst us Director Asian Cancer Institute, the very distinguished Sanjay Sharma sir. Please give it up for him. With an experience of more than 4 decades, he is one of the leading and renowned surgical oncologists, if I may say, we have in the country today. A gold medalist in academics, he has served at Tata Memorial Cancer Hospital, Parel, as a professor, surgeon, and head of Department of Thoracic Oncology and Breast Cancer Services. He additionally also has fellowships from Memorial's Sloan Kettering Cancer Center, USA, if I'm saying it out correctly, Cornell University and Stanford University. He has over 150 publications in national and international peer-reviewed journals. He's a proud recipient of several prestigious awards for his exemplary contribution to social service and educational performances in India and abroad. Sir is guiding the audience today with the topic of three-field esophagectomy in esophagus. I already lost my breath. Yeah, so let us hear it from him. Welcome, sir.
Thank you, Jimina, for kind introduction. First of all, after such an exhilarating presentation by him and so much of crowd who was so much aroused by the problems that they are seeing and they want to solve the problems. So it's a good idea to have such sort of CMEs or presentations, and as Dr. Deepak Parekh did mention that we have to have more such things involving even the hires and a lot of other NGOs also to attend the meeting rather than only the medicos, because the problem we only see limited, but these NGOs and all, if they attend these questions, the questions and answers that were going on, then will take it long way. Anyway, come from the jungle that we have. Now I have to be, I don't know whether I have this audience. I wish I had got something else. But anyway, after what we have learned, what is the cause of oral cancers, cancer esophagus is not less. So, I bring the readings from the Asian Cancer Institute, from the center as well as from ACI Acharya Nanesh, and I thank my colleagues to have arranged this meeting for all of us. Now let's come to the cancer esophagus. Cancer esophagus is, people don't talk about this too much, but the incidence is increasing everywhere, and you can see that is the global data. The cancer esophagus here, on paper it's about 1% on world. But the mortality is quite light. More than 5.5 lakh people die every year. That is 5.6%. That is unfortunately the reality. Now you can see this is again, sorry, go back. Like this? Yeah, only this one. You can see here the Central Asia is about 7% male and female, and see the mortality 5.6%, 5.7%. See the population that we are going to hold, and we are holding all over. It's tremendous, and unfortunately, it's a very difficult problem to handle, and very few people try and take that. So the service providers are also very limited. You can see this now estimate over next 20 years. See that. China is increasing almost to 1.61%, India is 161% rise in next 20 years. And see the mortality also is going to go up here with this. Here they mentioned the mortality. See that 166% is 9. So how many patients are dying? Because really we are not able to save them because they come in quite late. So what kind of cancer esophagus that we get? And I talked to you about later just to tell you what is the demography that we have. Majority of patients are basically comes up in the middle third of the esophagus. Upper and lower are still lower, less number. And we have 87%, this is of course the TMS data taken some years back, 87% are stage 3, stage 4. The detection is late. And the reason is, we give excuses to our difficulty in swallowing. आपका घर में बहुत अच्छा खाना खाया, आज इच्छा नहीं हो रही, हार्ट बर्न हो रहा है. कल कुछ नहीं खाया, इसलिए तकलीफ हो रही है. कल बहुत ज़्यादा दारू पी लिया, इसके लिए हो रही है. But we don't realize these symptoms are persisting. So unfortunately, Indians have a habit to somehow do not concentrate on our symptoms at all. We are generally in India happens. It's not that me or you or everybody. Practically about 90% of the population would do that. The complaint that people present with difficulty in swallowing, painful swallowing, this is quite late. Swallowing food becomes tough, this is again late. What happens first is this: heartburn, acid regurgitation, chest pain, behind knee, or these things. This is more common. Even if you have multiple causes, when I come to it, that things are more for the lower in the esophagus. Now, as you can see, if you have esophagitis or this, there is a scarring or narrowing. This causes symptom. Better esophagus, I just showed you, and I but mentioned by him also that there is a change happen because of the causes of cancer. That is partly responsible. This bad esophagus is causing changes in mucosal pattern. It could be either by eating the positive factors, or as well because of the increased GERD, as what Priya mentioned. Because India, majority of problem from heart to all kinds of diseases is all your body, the middle GERD size. If you remove that, 50% of the problems are solved. And this is, see the balance done. Can I have this light little low means I don't, because it's not seen properly. Can they be put out for a minute, please? So, see this thing. These are Barrett's esophagus. And this is a precancerous condition. And how will you judge it? You can't judge it at all till you have symptoms. And if you ignore the symptoms and don't get an endoscopy done, they will become into a frank cancer. So what are the causes? I had mentioned, smoking is not so much a problem in India, but smoking with alcohol is no problem abroad, which is causing the cancer esophagus. And as Sagar mentioned, betel nut, elephant nut, they are very complicated. Ladies, especially in Rajasthan, chikni supari, Indore, good, maximum number of conduct and about betel nuts are taken. There is an endemic area in the country, elephant nut is in Assam. They produce this, they sell it, they survive on it, but they eat it. And probably the maximum amount of incidence of cancer esophagus is huge in this part of the world. Then again, as I said, GERD, your gut is causing GERD and causing GERD esophagus, which is a condition which can give rise to the disease here. What do you do in investigation? Unfortunately, whenever some people, patient goes to a general practitioner, they try to do an X-ray chest or do a barium solve. The problem is eating heartburn that needs endoscopy. May not be thinking of cancer, but all kinds of this like precancerous condition or your GERD or your also a problem arising out of esophagitis can be solved by endoscopy. So if you have any problem with burping, the persistent heartburn, endoscopy is the best thing, which is very, very simple, and I'm sure our experts, gastroenterologists are very, very efficient to find out if there is a disease. They do a biopsy of maybe benign or other condition. If you prove cancer, then you can just do CT scan, that is PET scan, which is important, that gives you in one shot the dissemination, if any, before you plant. And once you are found out, you need to have a good heart checkup done on a lung function checkup done for the precise reason that they ultimately, that's okay. That is very important to do that. So what is the point? Stop smoking, and as you mentioned, yes, drinking is allowed, underlying moderation. Management of gastrointestinal reflux disease, reduce your body weight, which will reduce it by 50%, and then there is a chance that your dehydration will not take place. But once you have a loose LES system, because of initial GERD, that sometimes need surgeries, like when you have hiatus hernia, you have other procedures which can be done laparoscopically to prevent that. And of course, you have an HPV, which is very, very common, as is mentioned in India. Oral cancer is also one of the reasons where we have a lot of these things are there. In India again, most of the cancers are squamous cancer because our disease is more in upper and middle. G junction is basically now increasing because India is trying to become affluent. People are becoming again healthy, unhealthy but fat and causing these kinds of problems, and I did mention that. So you can see now this rising curve is actually the squamous cancer was there in India before and adenocarcinoma in India. Now the things are reversed. Now we have more and more adenocarcinomas and less squamous cancers. As we are increasing there, increased number of adenocarcinomas and increasing because the problem is more lower down. So how do you stage that? Just to tell you broadly how any cancer staging is done. What is the invasion of the mucosa, where the disease starts? So if you have very early disease with no nodes, stage 1 or stage 0, and similarly increase the number of nodes and increase the number of, increase the depth. So you are up to muscle level is fine, but beyond it goes into the structure and this becomes really an inoperable case. So there we need to have understanding that how disease spreads. Now treatment of cancer esophagus. This is a case of barrel esophagus and there is a lesion there. And this is a narrow band imaging. If you do that, you can find out this is a precancerous condition. Sometimes there is a very early adenocarcinoma in this. So how do you treat that? Now our endoscopists, our medical gastroenterologists are fantastic. They do what you call an endoscopic dissection, submucous dissection of this lesion. So this is the lesion. See this whole portion has been removed by the endoscopic picture. Treatment is over. That's why I insisted initially that you should insist upon, as the physicians that you should, instead of doing X-rays and all, send them to a good ophthalmology, gastroenterology, the problem is sorted out then in there itself. Of course, you have to, guide your person not to have all the reasons which are required for, to reduce the disease process. Advanced cases, the treatment is combination. You can't only operate or you can't only give radiation therapy, and I'll give you an example of that. So today, this is the standard of care, neoadjuvant therapy. It could be either chemotherapy plus surgery or chemoradiotherapy plus surgery to do a radical surgery. And I'll go on and mention about it why I will insist on doing radical surgery. So surgery alone still is gold standard. Radiation alone, if patient is unfit for surgery, you can either give some palliation by giving some radiation therapy and all, or you can just, after radiation therapy, put in a small little stent so that he can at least, or he or she can have a food there. Now, the standard treatment care is progress with, surgery consists already standard of the care, as I said. Progress with adjuvant CT-RT and chemotherapy alone, or and primary organ dissection along with this, with equal number of lymph nodes. Now, what's point out to any cancer you treat, solid tumor specifically, nodal disease is the problem. Primary is one here, but when the disease goes from one station to second station, where the problem starts. So if you do this, but do not do this, no point. So you have to remove all that thing to get into an R0 clearance. And that's why now that surgery is nowhere. Best all over the world is this treatment to be done, either CT-RT or CT chemotherapy and then surgery. So management of esophageal cancer is again multimodal. You can give neoadjuvant chemotherapy, neoadjuvant and then operate, or you have decent meta-analysis does show that there is a benefit, almost about 8.5% benefit as compared to in both the histologies if they have to save the patients. Now, surgery is gold standard, and I said either you give a chemo-RT or only RT. But alone radiation therapy is not important, and we in Mumbai also, my colleague Badwe was that time a registrar, they did it along with Dr. Simon Law from Hong Kong, and they published this data, and our data mentioned that only radiation therapy is not a good idea. And definitive CT-RT versus alone, they mentioned that in early cases the results are almost the same. Probably yes, but in these cases, I will mention later that it is not only the question of just controlling the disease, but other problems that arise after giving radiation therapy later on. So what I said the different types of surgery, and I'm not going to go into details. And I'll mention what we do. So I just to explain, segmental resection means you take a part of the segment of the esophagus. So either lower end or upper end, but only upper end, you can't just remove only the segment. You can't just join esophagus with esophagus. Lower cancer, you just remove a small segment, and I'll explain to you how we proceeded beyond that. And then we increase the different kinds of Lewis Standard procedure, trans-hardy. Yes, there was one gentleman from United States, Mark Orenja. I think we did more than 4,000 cases by removing the esophagus by doing fingers. Of course, there were early cases, but he had almost about 15% patients surviving without this thing, and mortality was almost negligible. But unfortunately, that nodal clearance was not there, and that's why this treatment is totally given away. Now we do what we call a strong thoracic esophageectomy by different kinds of method, conventional, radical, and by using minimally invasive surgery like any other surgery nowadays required, is doing wax and this and that. And of course, lymph node dissection, there are 2-3 types of dissection: local, regional, and complete, total whole body, 3-field. And of course, yes, we also had a robot. We did some cases earlier, but unfortunately at Kambala we don't have that. We had that period was phased out, so now we are trying to get that one more robo, and then because we had other type of robo, but that was not sufficient enough to do these cases. So now we're trying getting back to the Da Vinci system. So hopefully we'll have this after some time, and then we'll work again. There are multiple trials. Again, I don't want to go into details. You can do, if there's one in the Netherlands trial, Dutch trial, they mentioned that you give radiation therapy and then operate. But there were a lot of discordance in case reduction in India. So though entire Europe uses this, but in India and other parts of Eastern countries do not follow this. There are new protocols now for food pipe cancer, downstairs, adenocarcinoma. There is a new trial, the fraud trial, fantastic result. Just give chemotherapy, though it is toxic, but whole tumor practically disappears, and in that case surgery becomes difficult, easy. And then Japanese studies, now they have confirmed that you do NSCT or you CTRT, the results are the same. But if you give radiation therapy, according to them, even Japanese, and so I refined, and I mentioned you our outcome and our complications of radiation therapy with our environment, our patients have poor lung functions. Their complications of surgery are very high because these are very difficult surgery doing in the thorax. So we do what Japanese do, as only give chemotherapy and then operate. Now I'll just give you what, sorry, something happened. Okay. Yeah, I have a very small experience of handling these cases for almost 45 years. When I joined RMO in 78, that time Dr. ACI and team used to do only left side thoracoabdominal surgery from lower third esophagus. And we did almost about 900 odd cases, and I'll tell you that later. Then in second phase, when myself, Dr. Deshpande, and other people started going abroad, we went to Europe, we started doing this standard procedure where we used to midline as well as right thoracoid and take the esophagus halfway down without massive dissection of the nose. And in third phase, when I started going to Japan and United States and other people, they started doing complete nephronectomy, and now I have known that of almost, you can say almost 15, 16 years. And I've done more than 900 odd patients. That's our experience, and now we follow up the same thing in Asian cancer. So in early, as I said, in early 70s, the survival was only 5% and high recurrence was 45%. That was the reason. For patients, mostly we used to do the lower end. Then we started Louis standard procedure. You can see we improved the survival from 5 to 10%, but local recurrence still remained high. And there were 600 cases. These are all published data. So you can see here, this is the bulky tumor here. I'm operating on left thoracoabdomen. That's aortic arch here, and that's esophagus. That's a margin used to do local disease, local nodal clearance. Then we went into Louis standard procedure, where we do midline, right side surgery, complete abdomen thorax to be done, and see the carina and all these nodes are removed. So this is Louis standard procedure. Because when we don't do the IRP in the neck. And then we started, we realized that from out of 100 patients that we get, 50% are very advanced. We can't do anything. Locally advanced cancers, at least we give chemoradiotherapy, and operable cancer, now almost 50% of patients we are giving meaningful life, and we are saving their lives. And that's the reason why we thought about, as all over the world they said, we should start doing lymphadenectomies. Initially we used to do this much lymphadenectomy in abdomen and lower end. Slowly we increase the lymphadenectomy from here going up to the neck. That's called a three-field dissection. So that's a specimen here, and when we remove this organ, we replace it with stomach, and stomach is the best organ. If you don't find, you can take colon and put it, but this is the best organ when done. And it will prove now that if you have to replace it with this, and we make a small tube, thin tube, where you can have 6-7 meals because there is no stomach left there, but then people get used to it and they do fairly well. But in advanced case, what do? Either you give radiation therapy, but if he is stenotic, in such cases we dilate and try and put in a stent, and there are fantastic stents available. If it is advanced disseminated case, but don't put it in the case where there is a chance to operate or save. Don't do that. Try and find out if there is scope of giving chemotherapy and operating. Don't put the stent, because once you put the stent, sometimes the stent gets penetrated into the mucosa and esophagus, and you can't operate it. And then you give the best chance for the patient to go away. That should avoid that. Radical therapy, as I said, in the 90s I started with my, of course, by blessings of my seniors. And the goal is again to get R0 clearance and reduce the mortality and increase the survival. So we did open thoracotomy. This we do still to get a good circumferential clearance and good longitudinal margin. Yes, we did some amount of cases. Non-randomized studies have shown that there is no difference between the minimally invasive surgery, robotic surgery, and the door open. But mostly these data are from abroad, and their patients have very different, very low lymph node ratios. They have less. Our lymph nodes are big ones in spite of that. And then our patients are right now. So we give chemotherapy, there are a lot of pulmonary complications happens. So they are not as I said that the complications are less. No. Open surgery, we are doing it. Yes, there are the hospital stay increases, pain, but with epidural catheters and all, the pain, everything has gone away. So we are still sticking to it, except in very early cases we do minimally invasive surgery. And how much margin? So minimum, why you should do total hysterectomy? 10 centimeter margin is to be removed. So if you remove 10 centimeter esophagus, practically half of the esophagus, 3/4 is gone. So you have to remove that because that is required for survival. Similarly, circumferential margins, you need to have clear margin. Lymph-in-free margin, at least 1 millimeter margin from the tumor should be there to save the patients. And this says that, sorry, my fault. So circumferential margin, then you have to remove lymph nodes. So if you have to remove all the lymph nodes to survive, and they are supracarinal, that means over the carina, or intracarinal, depending on location of the tumor. But you have to remove practically because they are, even in lower cases, the node goes up to the neck, to the nose, so you have to remove that. And you have to remove more nodes. So if you have sort of more advanced the cancer, a lot of nodes are positive, and you need to remove that. So this is standard. We started doing these cancer surgery earlier. There were two fields where only lower end was done. Then we started doing loose channel procedure. We do only up to here, and then now we started doing 3 field. We remove all these lymph nodes at the same time of surgery. And this is, you can see, this is a 3 field dissection. These are the esophagus completely removed. All these lymph nodes from here. This is the trachea, the windpipe, and there is vocal cord. So if you do surgery, you have to save the vocal cord, otherwise you become hoarse. Similarly, left side now. So this is a complex procedure. And see the dissection. There are pancreas, there are glands, and there are vessels. This is the way you should remove it. So what is the organ that you want to take? As I mentioned, you can take stomach, or if required, you can take the colon upstairs. The operation is not a very complex. So in anastomosis, hand to hand, or you can do staplers now. The staple on staple anastomosis become very serious. But in India, because the patient, the condition is not too good, we put feeding geniostomy in all patients. They start feeding from day 1, and then on 7th day we get the things, the gastrographic study, they do leave, we give them orally, and they go home in 9 days. So it is direct, under direct vision we do this surgery, and more and more we remove, especially in transmural disease, the survival chances are better. So this survival advantage is more if you have more than more than 23 nodes. That's multiple trials that prove that you should remove practically minimum 23 nodes required. And in the positivity of lymph node to positivity from the node you retrieve, that ratio also is important to save the lives. And now I have only 3 more slides to show. This is the way we started in period 1, where our mortality was 6%, we brought it down in present area to 0. We don't lose patients for surgery. You can see the overall is less than 1%. Leukotrienal recurrence was 12%, we brought down to 3%. Pulmonary complication was 22%, we brought down to 10%. Leak rate was initially 5%, we come down to almost 0. We don't, any patient will have no leaks. And there are other things that we improved over the years. Our teams are very, very efficient, our colleagues are excellent, so that has been carried forward. And I can tell you, this is the data. I'm just trying to show you that we are no less than anybody in the world. This is Dr. Akiyama, Dr. Fujita, they are top people in the world, in Japan, of this doing surgery. Dr. Fujita, then Dr. Nehru from Belgium, Dr. Turkey from the United States, and similarly one last slide, this one slide I think I did not discuss. You can see the complication of other people. See, Dr. Akiyama is treated for 2%. So we are no less than in complication, we are practically matching everybody in the world. So we have reached that stage. Sometimes we are better here. Our patients are younger, their patients are very elderly, so they have a lot of other problems which we don't have. And you can see the results. So survival, Dr. Akiyama 52%, ours is almost 57% in a node positive patient. Even node negative, I have a 10-year survival, 93% in this group of patients. So we have succeeded because of, as I said, the good teamwork. So that's why now we are very, very happy to have that. But is surgery only solution? Probably now, in times to come, we have a new kid on block. That is immunotherapy. Now, practically the tumor MSI high, and is relatively young, older, elder person. You don't have to operate. Probably you may just, today we are using it in advanced metastatic disease. When in future, probably, you only give immunotherapy and the whole thing will disappear. Surgery may not be there at all. So we are looking for that time that we don't have to do such major surgeries. Especially with every place has not so much of facilities available. So this is to be remembered by all of us. Now I'm just replaying this one video of this girl which I operated. How do you put it on? This one. Yeah. This I operated in 2008. I can't hear it. 1 minute. Stop. 1 minute. Yeah, I've got more than, I think more than 700 patients alive, and it gives very great heartening feeling to patients living for more than 10 years, 15 years. I have a patient who is living for 25 years. Last time he called me that it is my 25th birthday, and he called me from Assam. I went and operated him in Assam. He's still alive, and every birthday he says, "Sir, bless me, I am now 25 years." So it gives me a very good feeling. Sorry, when you
उसके बाद से वगैरह उन्हें किस्म कार्सिनोमा डिटेक्ट हुआ। फिर डॉक्टर साहब ने मेरी सर्जरी करी थी, 3 प्लेट सर्जरी करी थी, पेट, ब्रेस्ट और यहाँ से जैसे कार्डियक सर्जरी। सर्जरी के बाद मैं 1 मिनट ठीक है, समझ में आ गया।
Sorry, I thought he was working before.
मैं जब खाना खाती थी मेरा खाना पीछे नाक के फंस जाता। मैं 30 साल की एज में मुझे प्रॉब्लम हुई थी। उसके बाद मैंने कई डॉक्टर्स को दिखाया, पता नहीं चला था, यहाँ पीछे भी दर्द हो रहा था मेरी बैक जगह पॉइंट पे। फिर मेरी एंडोस्कोपी हुई तो उसमें यहाँ पे एक गांठ दिखाई दी। उसके बाद से वगैरह उन्हें किस्म कार्सिनोमा डिटेक्ट हुआ। फिर डॉक्टर साहब ने मेरी सर्जरी करी थी, 3 प्लेट सर्जरी करी थी, पेट, ब्रेस्ट और यहाँ से 3 जैसे काट की सर्जरी करी थी। और मेरी टीम वगैरह हुई थी, गैलेक्स था कास्मेट। सर्जरी के बाद मैं 2 महीने में बिल्कुल फिट हो गई थी। वो ऐसे ट्रीटमेंट डेट से नहीं पड़ती है मुझे, वैसे कोई दिक्कत नहीं, अब आदत हो गई है। और सर्जरी के 2 साल बाद मेरी बेटी हुई जो अब 5.5 साल की है।
Now she is 14 years.
पहले बहुत मोटी थी, अपने को ऐसा समझती थी कि मैं ज्यादा थोड़ी चलो छोटी मोटी प्रॉब्लम्स रहती है
She has a big jewelry shop in Delhi. After she started her own self, and daughter is now in, I think she's in early college, and I'm presenting this because people are apprehensive of doing surgery. So if you go to people like Prashant, people who are more efficient in handling such cases, this should be done, and you should not be saying that you are too advanced and leave them alone. Now, I brought this point only to say that we have people here, we have means now to handle such cases, and I will be happy if tomorrow immunotherapy comes up, patients are having no complete cure without surgery. Thank you very much for taking it.
It's a very basic question. So I'm a general practitioner.
Ma'am, just
Yeah. आपको या
everyone want to understand your question.
So आपको या हमको हर किसी को कभी ना कभी हार्ट बर्न होता है, सब लोग पेंटाप्रोजोल या रेबिप्रोजोल खाते हैं, इतने पेशेंट्स आते हैं गैस एसिडिटी के, लोग अपने मन से एंटासिड्स खाते हैं. सो कब पेशेंट को एंडोस्कोपी के लिए भेजना है, कब मैं ये सस्पेक्ट करूं कि यार इसको इसोफेगस कैंसर हो सकता है?
नहीं, मैं एग्री करता हूँ, दिस इज ए वेरी कॉमन प्रॉब्लम. आई डोंट लुक एट कि आई हैव टू सेंड द पेशेंट टू endoscopist for esophagus. I want to tell him and show him or her that your problem is different. You have a gastric esophagitis, you have a Barrett's esophagus. That can be treated, and that could be even because of gut, your health, your gut from here. Good, make that, or you have what we call as today we do a fundoplication. So the relocation will take place. So those patients who are persistent in coming to you every 2 months or 3 months with this, they are the candidate that you should send for at least endoscopy to rule out not malignancy, rule out other problems which are giving rise to cancer in future. That is important. कैंसर होने के बाद में तो सबको अटक नहीं लगता तो अपने आप ही करना है, लेकिन प्रिवेंशन के लिए आपको पेशेंट को उस तरह में देना चाहिए जब ये बहुत डिफिकल्ट आपके पास पेंटोसिस खा के आते हैं.
और जैसे बहुत सारे पेशेंट ड्रग इंड्यूस्ड है, या कितने मैंने देखा कार्डियक पेशेंट है या जो जिनको जिंदगी भर मेडिसिन चल रही है, उसमें एक पेंटाप्रोजोल once in a day early morning before वो पेशेंट कंटिन्यूअसली खा रहे होते हैं.
Which unfortunately find no reality, but actually if we go through the literature and everything, the advantage of that only is limited if we use for a limited period of time. But it becomes a plastic, we never work that way.
पर पेशेंट हमेशा
नहीं, but उनका psychological है, psychological. I'm telling you, you go to the literature, ask any gastroenterologist. They won't deny that the person is eating for last 1 year or 2 years or 3 years. In that case, you need to find out why is having so.
Sir,
Any question?
dysphagia
Yes.
for liquids, not for solids.
take this.
Well, very good question. Now, बोलिए.
Dysphagia for starting for the first liquids first, not for solids.
सर ये जो आप जो न्यूरोलॉजी के डिपार्टमेंट होते हैं ना,
Yes.
एग्रीमेंट कार्डियो हो गया या हाइड्रोसाइनिया में जो कम होता है ना, रेकलेजिया कार्डियो वन कंडीशन इन विच द सॉलिड स्टिल गोज, बट बिकॉज ऑफ द physiological problems, the nerve problems, because of the weight in the body, liquid that you drink, the solid food with the weight goes down, and that problem occurs in the esophagus patient also. हम तो उनके नर्व काट देते थे, उनको भी हम लोग को समझना पड़ता है कि नहीं लिक्विड थोड़ा थोड़ा खाओ, और लिक्विड खाना है तो पहले सॉलिड खाओ बाद में लिक्विड खाओ, जैसे कि लिक्विड के साथ में सॉलिड के साथ में भी लिक्विड चले जा सकते. But your point correct is not uncommon. It's there, and we should. I mean, that is a good question.
Repeated H. pylori infection.
That is a major problem. I wish the world knows how to get it ready and get it. But yes, you have to be careful about that. It is usually our food related, our diet related, these are the thing. Unfortunately, H. pylori is in population everywhere.
Thank you.
Thank you very much. Thank you. I really appreciate it.
Thank you, sir. Thank you. Next up, the final concluding session for today afternoon. We have with us Dr. Deepak Parikh, and I am going to take 2 minutes to introduce him here. Again, a stalwart from the field of surgical oncology, director and also the chief of head and neck and laser services at Asian Cancer Institute. That is just one of the many ways to introduce sir. Other ways would be the fact that this is also his 4th decade imparting valued services towards oncology. Also having served at Tata Memorial Hospital, Parel for more than 20 years. His special interest is clinical applications of laser surgery and photodynamic laser therapy in both early and advanced cancer and advanced head and neck tumors, especially of the larynx. An active teacher for postgraduates in surgical oncology, he has authored numerous publications and is an invited speaker in over 100 national and international conferences. He is a recipient of fellowships and awards of many national and international societies. He is invited as a visiting professor faculty both in India and abroad in numerous laser operative workshops and training programs. Sir will speak about current concepts and advances in management of head and neck cancer, and then we love to hear from him, and also I think this is going to give a rise to a lot of questions and we would love to take them. Thank you. Handing it over to Parekh sir.
Good afternoon. I'll be talking, as I mentioned, on advances in head and neck cancer. Advances in the management and the detection and early diagnosis of cancer. Part of the lectures have already been taken, which has been good for me, so I can concentrate more on the other aspects. But I will touch briefly on those issues as well. Not to take too much time in the introductions, because I think I stand between you and your lunch, which you all are eagerly waiting for. So let's get on with it. Anyone can explain the first two words, ostrich effect and cancer? Do you know the word ostrich, Australia? It hides its head in the mud when it sees a predator, somebody come to kill it. It hides itself thinking that I can't see it, so it cannot see me. Its whole body is outside. That is what unfortunately happens when a person is told that possibly there is a cancer or there is a cancer. And when you see something odd in your mouth, especially I'll be talking on the head and neck and oral cancer, and when you see something that's different in your mouth, then it cancer मुझे थोड़ी हो सकता है. Like was discussed already, मैं सुपारी नहीं खाता हूँ, मैं तंबाकू नहीं लेता हूँ, मैं दारू नहीं पीता हूँ, खाना है, तो मेरे को थोड़ी हो सकता है कैंसर. Unfortunately, reality is it still does happen. The risk increases with all these listed factors, but it doesn't mean that because you don't take that, you will not get a cancer. So remember, cancer can hit anyone at any time. The other problem of the fear of the cancer is lack of information, which has changed a lot with the internet, with the web. Unfortunately, a lot of wrong things are even being put in, and that is where it leads to a lot of misleading and the unreliable information sources, which is what the internet is doing now. And one of the major crux one has to understand is, if somebody tells you that he's going to cure you of your cancer, it is impossible. It's like somebody telling you you're going to get cured of your diabetes. It is not. Yes, you might avoid drugs, medicines, etc. because you've changed your lifestyle. You're careful with your lifestyle now that you know that you are a diabetic. So same true is with cancer. If you change your lifestyles and all, once treated or pre-treatment given for precancerous, it can make its impact. This I think we all know. Just to repeat, the main areas as far as I would be concerned would be the unusual bleeding or the last couple of them, nagging cough or hoarseness or a white patch in the mouth. This is what applies for head and neck cancer. Partly difficulty in swallowing also does when you talk of the oropharynx or the base of the tongue lesions, which are blind areas when you are examining. Now this is what we have discussed about. Can you make head or tail? I can't. After 40 years, I'm sure even Sanjay with 40 years, as surgeons, so we don't understand this. The moment there is a medical oncology talk and they put up a slide like this, I mentally tune out. I don't know what the hell they're talking about. So now how many of y'all came into medicine because y'all didn't like maths? Isn't there? Sorry, you'll have to go back to maths now. Because what's coming in fact we just recently had a talk at the ACI of artificial intelligence. They are going to help us solve this, but for that you have to know a little bit of mathematics. because you're not going to be able to understand it otherwise. They're going to simplify this whole complex formula that you see the various points where cancers can hit and what medicines are bringing. Offhand I can count at least there are 100 points where cancers can start. And the problem that happens with cancers is it is heterogeneous. Like what Sanjay mentioned, from squamous it's changing to adenocarcinoma. The whole picture is changing over years. So similarly, cancer is not uniform, it's just apples or just oranges in a tumor that you will see in the mouth. There will be different classifications which was very simple in my days when we learned, also it's well differentiated, moderately or highly differentiated tumors. Today it's going to molecular biology, it's going back to the slide over here. We will talk of all the different levels, whether it's PD-L1 positive, negative, ER, PR, blah, 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 it just goes on. So this is where artificial intelligence is going to help us out. They're already working on medications and things which will help a clinician determine in a given tissue sample for a given patient what is the best option of treatment for that patient. Whether it is surgery, immunotherapy, tumor markers, targeted therapy or chemotherapy or a combination of them is what we'll have to look at. And based on this even we'll probably be able to get to which, as was mentioned by Dr. Sagar, you saw the different types of leukoplakias. So will you treat all leukoplakias or are there in that risk factors which are highly more potential to turn into malignancy? Often it is said between 10 to 20% in different various publications will change into cancer. But the problem is the patient sitting in front of you is consulting you. He's a one patient. You can't tell him you have a 10% chance. If there are 100 like you might be one of the 10. He's interested, am I that 10 or not? And that is where the problem starts. That probably with all these kind of understanding that we're going to molecular biology, we'll be able to wean out those high risk groups, concentrate more on the treatment, do effective treatment for them. Unfortunately, as was mentioned, somebody talked about tobacco, this is a stark reality. 11,000 new users every day in India. And the current estimate is by the next couple of years, India is going to see anywhere between 20 to 25 lakh new cancers a year. How are we going to manage these cases? We don't have that many oncologists to manage 25 lakh new cancers, forget the old cancers. And what little experience that I have been able to, and if I can sum up my oncology experience of 40 years. When we started, as Sanjay showed the different phases of life, we all have gone through that. Probably the first 5 to 10 years, even in head and neck, our survival results were hardly about 15-20% at 2 years. Over a period of time, we have seen we have improved that remarkably. Today now, even I would have patients which are 10, 15, 20 years ago operated, treated, and were surviving. But unfortunately, what I'm seeing today is they're developing a second cancer or a third cancer in the oral cavity. And that is the problem with head and neck cancers. It is loco-regional. Very, very rarely will it go metastasize to the lungs or to the liver or to the brain. It's an odd one out. Unlike a cancer lung, which very often presents with a metastatic disease rather than a primary. But problem with head and neck cancer is it can recur at a different site. So if you've got a right side pulpal mucosa which you have treated, then it goes after 5 years to the left and then it might go to the tongue. So you have different sites. So what has changed for the oncologist today is if he's getting a young patient, which is again a very common thing. I remember in my youthful days, the moment a 25-year-old patient came with an oral cancer, not only would we treat him of course, but we'd be busy writing out a paper to try and present it. A 25-year-old guy has got cancer and it will get published. Today it's a run-of-the-mill. 25-30 is a very common age. In fact, I've done an 18-year-old boy's laryngectomy. And the reason? From the 3rd, 4th standard, he had started taking the gutka. So what is required for tobacco is about 10 to 12 years. And that is why I say when talking of tobacco versus alcohol, if someone were to ask me, not that I approve of it, but alcohol is a better bet. Why? You have 2 pegs or 3 pegs. And the day you take 6 pegs, the next day you get up with such a thing that you vouch never to have more than 2, if at all to have. Unfortunately with tobacco, it takes 10 years, it's not the next day. So what you have been consuming over 8, 10 years then starts showing the changes, by which time it is too late. So what you asked about early detection, this is the problem with oral cancers. That it's a positive thing it takes so long, but it's a negative thing because you don't realize, and so the consumer, whoever is the habitual person, keeps on consuming it. And very often another common story, that patient comes along, first time consultation, I see a cancer, and obviously asked, I stopped asking even now because I know he's going to tell a lie, कि कितने सालों से खा रहे हो? नहीं साहब अभी तो बंद कर दिए. अच्छा बंद कर दिए. कभी बंद किया? कल किया, परसों किया, 6 महीने पहले किया? नहीं साहब कम कर दिए. So my usual answer for this is कम किया या नहीं किया? पहले आप 10 माले से कूदते हो और अभी आप 5 माले से कूदते हो, चलेगा क्या? It's the same effect. Even one floor is enough to kill you. So remember, this is pure poison. There is no other word for it. It's just in low doses you take it relatively, and the effect is so delayed that you don't realize it. And the other factor comes in is, sir, kharcha kitna hoga? And this is when I pull out this chart. To explain it, let's say for 5 years, I take half a packet of cigarette, it's 55,000 rupees. And if it's for 1 year, it's 1,10,000. And for 3 years, it's 3,30,000. Most of head neck surgeries, even with reconstruction, will usually in a kind of a general ward be done within this much. So the 3 years that you've been consuming tobacco is what is going to be your cost. Rub it into the, hammer it down into the brain, and this is what you have already burnt up. Imagine if this is a simple calculation, there's not even interest and compounded interest and investments in the stock market. Without all that, there's the actual cost what you have literally burnt up. And I really appreciate what Nepal does. Nepal, for every tobacco packet or any consumption product of tobacco sold, a percentage of it goes to the cancer hospital. So in short, you're paying the premium of insurance for your healthcare by consuming the tobacco. That money is diverted and kept for the cancer treatment. So long and short of it is, especially for head, neck and lung cancers, tobacco and betel nut and all the other products which have been mentioned both by Priya and Sagar, I think there's not a word for it of decreasing it, it's just eradicated. Very simply said, as we discussed, the factors, the job, the industry that is there is so strong. And just to add a little more to what Sanjay had said about the court matter, unfortunately when it went to the Supreme Court ruled that this is not a state matter, this is an all India jurisdiction of eliminating tobacco. And that's where we hit the brick wall. To eliminate tobacco all over India with a population of 1.4 billion, I think it's going to take that many years, 1.4 billion to stop it. So it's a thankless, impossible task as I see it. The only way to do it is to educate them and start at school level. You will be surprised. In fact, this slide, I've shown this slide and pulled up and shown it, this is the corrected slide, a similar one, and some person from the audience got up and told me, sir, if you don't mind, I'd like to correct you, and he gave me the correct figures. This was a 5th standard school kid. So he knew the cost of cigarettes more than I knew, because I don't smoke, so I have no concept. Probably mine was a 10-year-old calculation of rates. But that boy knew when he calculated and he told me that these are the wrong figures. So it starts off right, the 5th standard kid doing it. And we all know the reasons, peer pressure, crowd, to be one-upmanship, etc., etc. Fortunately, the government has changed with all the kind of advertisements and all that effects, but still, it's a long way off. Somebody had mentioned again about the tumor markers. As far as head neck is concerned, as of today, there is no effective guaranteed tumor marker which works. Basic bottom line does come to biopsy only to prove whether it's cancer or not. And as was mentioned by one of the speakers, tuberculosis is something you should not forget. So any patient whom you're treating as tuberculosis, I would strongly advise don't do it empirically. Try and prove it, because you have numerous tests, you have tissue samples, needle biopsies if there is a more, and then start on treatment. Because invariably what happens, you give a 6 to 8 week trial of AKT, by which time if it is a cancer, unfortunately, an operable or a treatable becomes inoperable. So please prove that it is tuberculosis before starting treatment and don't blindly start treating it. We talk about the endoscopy, CT scan and MRI, they are the standard tests of course. And this is the region that we talk about when we talk about head neck. Not only is it the oral cavity, which is the dominant one in India because of the habits. Talking of gutkhas and all, just I happened to get up early in the morning with me giving lectures like this all over the country. I got up early and went into the kitchen to make my own cup of coffee, and I got a peculiar smell which was very familiar, but I couldn't place it till I saw my maid servant take out the mystery and brushing her teeth with it. And I blew a fuse. Here I'm giving lectures to the whole world, under my nose, in my house, is my maid servant brushing. So I do a lot of coaching and guiding, but that is something that we need to look at. Start it off at your own level. One of the suggestions at this moment I would make is, let's try and make this day, there's also the Head and Neck Cancer World Day. These 2 days we have all the clinicians over here who are the frontline people who see patients. Let our hospital tie with them, support them. In your own clinics you all run the things. We will guide you, we will give you the sets. See, publicize the facts so more and more public comes to you. You see, it's obvious. Today if I tell somebody that go to this hospital to get yourself checked up for cancer, cancer, that ostrich effect. But he's known to you all. He's regularly coming to you all, the family members. Spend a little time of knowing their history, how many are consumers, tobacco related and all. And the best bet is hit the youngsters. When the child goes and tells the father or the mother to stop using tobacco and explain to the child scientifically, don't say it's bad. You need to explain to them why. We can give you the slides, we can tell you the things, or maybe like, the MRs come with their brochures, something similar we can give you. Let the child go through that, and that will entice them to try and coax their parents to reduce, consume, stop all these products. So this is how we assess for a vocal cord cancer. Lights dimmed off, possible. So you can obviously make out there's a classical tumor over here on the right vocal cord at the anterior portion. This is the true vocal cord. And this is how we need to assess before we undertake any form of surgery. And this becomes very important with these new tools that we have. The picture clarity, the obvious lesion. See the skip lesion over here, separate from the main tumor. So these are the things that we need to assess today to have a 100% success rate in the treatment. Again, another tumor here, separate, and these are the kind of pictures that we have. Cancer spread to the glands in the head and neck. There are the different levels which are defined, and usually based on the level of the gland, we are able to look for the primary. The only drawback in the head and neck cancer is everything is accessible except the back of the tongue, the base of the tongue, and the oropharynx, especially in the pyriform fossa when you do an endoscopy. So what is the dictum for the base of the tongue? Even a clinician, like was mentioned, with a good illumination, you all can do this examination as well. What is the dictum for any abdominal examination? If you don't put your finger in, you put your foot in. Same as with base tongue. Even visually you cannot see it, you have to, and even the tongue itself, please wear a glove, palpate the finger, palpate the tongue, palpate the back of the tongue. You can easily do it, because you will be surprised, you might find something nodular over there, which is under the mucosa. And as you said, the early detection is like a volcano sitting underneath, which will erupt out when it ulcerates. Try and pick it up before all that happens. So palpate the tongue, and that is what is important from a clinical point of view. Stages of cancer has been mentioned, the earlier detected, the better is the cure rate. But what is peculiar in head neck is, even a stage 4 cancer still has a very good chance, because the staging is a little peculiar in head and neck. Usually when you mean by stage 4 cancer in any other side, it's gone to the metastasized to the lungs, to the brain, to the liver, etc. Here it is the adjoining structure, which is like what picture he showed. If it's a lip and the mandible is also involved, it becomes a stage 4. The skin, if it's involved, it becomes a stage 4. But that can easily be treated. It is still a good chance of curative intent. So the advantage of cancers of the head and neck is that even in a late stage, it can still be treated. And today with a lot of, as you showed and I will show you as well, some slides of the reconstruction. The usual cause of therapy, as was mentioned, stage 1 and 2 is either surgery or radiation, whereas stage 3, 4 will require all three probably, of surgery, radiation and with chemotherapy added to it. Today, of course, we have the newer methods of targeted therapy and immunotherapy added to this. And the unresectable usually goes to palliative, though some can be salvaged with neoadjuvant chemotherapy. That is, you upfront you give the chemotherapy, shrink the whole tumor, it does become operable, then you can operate these cases and then follow it with radiation. Coming to the main thing which I have been doing for the last 40 years now is the laser surgery. And what is it? Laser is an acronym. What does it stand for? LASER. So it is light amplification, stimulation, emission of radiation. Misnomers, there is no radiation actually. It is just, this is a laser, what I'm pointing. We all know that, the laser pointer. So that is exactly what it is. And they described this way back in 1960s in US. But in India we knew it centuries ago, hundreds and thousands of years ago. Where? Lord Shiva, third eye opens, a beam of light went and destroyed. That's exactly what this is. That's exactly what this is. So as far as I'm concerned, there is another example of medicine today which we have not yet achieved, but which was done thousands of years ago. Ganpati, head transplant. Now just imagine, my mobile is there, the mobile device. In 80s and probably, I think 80s would be the right time, did anyone imagine that from here I can talk with my daughter in New York, video chat, that I'd have such a device in my lifetime? So somebody did imagine it, somebody did develop it, and somebody built it and it's there for us. So again, this laser, the thing, it could have been imagined. There must have been technologies, there must have been methods at that time. Because how do you imagine a head transplant when today we are nowhere near it? We are talking of small organ transplants and we are not succeeding every time. So these technologies and all must have been there, they got washed out, they disappeared, God knows world wars or catastrophic events happened, but it was existing. And this is what the laser does. Just to briefly explain, this is the laser machine. This is the arm, which when connected to the microscope, you can do an endoscopic laser through the open mouth without actually. So the tumor that you saw, like I showed you on that endoscopy on the vocal cord, can be excised without a single cut on the patient. It's all done from through the mouth with the laser beam. You can excise it. I'll show a video clipping. And the patient, depending on the size of the tumor and what you excise, it can be from 1 millimeter going up to 6 centimeter tumors and removed from the mouth. And these patients, obviously, there is no difficulty as recovery and everything becomes like an endoscopy. It's very similar again to what we know today of doing a resection of the prostate gland with TUR endoscopically versus the open prostatectomy which we did a few decades ago. So this is a leukoplakia pre-treatment. You can see the extensive leukoplakia, and post-treatment everything on. The advantage, as I'll talk to you with the thing. So this is a case in point. You see the whole cancer buccal mucosa going up to the angle, technically a T4 because you can see it's going to the angle of the mouth over here. Okay, so what, I'll just explain. Now what is the CO2 laser? CO2 laser is totally invisible to the naked eye. That's the wavelength it is at. And hence it is combined with this very same helium neon beam, what you're seeing the red dot. That's why you'll see the red dot there. That's what the dot is, to tell you where the CO2 laser is actually. And using the joystick, for laser training, if anybody wants to do it with the microscope, use the video games with the joystick that we had. That's exactly what the CO2 laser does. And as you can see, I've done the marking with the laser so that I have adequate free margins of 1 centimeter. You can see the excision taking place totally through the thing with very, very minimal bleeding. Because the CO2 laser at the temperature it works, at the thermal damage that it creates, so-called, is it keeps coagulating whatever tissue you are cutting. It's an automatic process. Main advantage of the CO2 laser is it leaves no thermal tissue behind. Unlike a cautery or anything else where the deeper tissues get burned, and as a result you get an inflammatory reaction which leads to pain, swelling as well as infection. The CO2 laser actually cuts at 1/100th of a millimeter. So this very same setting which I am cutting out the tissue, I can actually take a single piece of paper and write my name on it like I would do with a pen, without going through the paper or burning the paper. So it's that precise, and you're able to, including here, as you can see, the angle of the mouth is being excised completely, and the tumor is being gradually peeled off as you would do for any conventional surgery. Unfortunately, I can't make this go faster. I don't know if there's a slight change. It doesn't show the band below there. It does. I don't think it's this. Mac shows that, unfortunately. No, that's it. So here you can see the whole thing going through, and basically you excise it like a conventional. I think there's a lot of misnomer about the CO2 laser vis-a-vis the surgery will carry on. You can see the whole tumor tissue being taken off. It's gone right up to the buccinator muscle, which is the full depth, keeping a safe base margin as well, and the side margins. The CO2 laser, you get tissue for diagnosis. So this whole specimen, as you can see, it's almost off now except for the retromolar posterior part. So this is the upper teeth, these are the lower teeth, and that's the back right at the angle of the mandible. So this whole thing is being excised with the tumor right in the center. So this whole thing can go for margins, for the base of excision, the different types. So you know whether any further additive treatment is required or not. The only advantage and maybe disadvantage to the plastic reconstructive surgeons, I don't need them. This entire area is kept raw. It epithelializes beautifully because the property of the CO2 laser is to stimulate collagen and fibrinogen. And that forms a meshwork on which the squamous epithelium grows back. You will see that towards the end. There's a buccal pad of fat that you're seeing there. So as the specimen is just about to come out now, that's the last bit. Okay, so that's the whole, you can see the whole area is kept raw. It's from the lower teeth to the upper teeth, angle of the mouth, right to the back. So you can imagine the area of resection is almost about 5 centimeters by 4 centimeters. The angle of the mouth was then just primarily sutured so as to maintain the competence with the labial margins. That's a defect in the skin, you can see that, which was excised through and through because it was overlapping onto that. That's the whole specimen out. And this is the post-op. This has healed, as well as the mouth opening is good and adequate. Full regular mouth opening, and now you will see the inside of the buccal mucosa, which is also fairly normal. Here you can see the buccal mucosa. So the advantage here, and as I mentioned earlier, potential likelihood of a second, third cancer developing, you still have all the other treatment modalities open for you. Because, and the laser again, as I say, you can keep repeating it unlike the other modalities like radiation, chemotherapy with its side effects. Because of the fact that laser, either you get fed up as a consultant doctor treating him or the patient gets fed up of you. Till then the laser can be done because it's very, very targeted specific area. Another case in point just to show you is the vocal cord cancer. That's the vocal cord. You can hardly realize the tumor, but if you look carefully, the thickness of the two cords are different. So you'll see that when it's reversed and put in, this is on the fiber optic. There you can see, look at this totally altered mucosa versus the blood vessels you can see on this. And again here with the CO2 laser, which is arm, you can excise this and peel off this tissue. A procedure which would be morning admission, surgery, 6-8 hours post anesthesia, takes cup of water, drinks well, goes home. It's a day care admission. You don't need to stay overnight. The treatment currently that would be advised for such a patient is radiation therapy, which is 6 weeks, every day going to hospital for getting this treatment done. Whereas there is a single sitting, one surgery with tissue diagnosis available for adequate. So seeing these kind of video pictures, seeing these early cancers, and that is the role of early detection. What does laser stand for? I told you it's an acronym for what? Who remembers? See the results. This is the next day and there is one of 5 years later. That's 5 years later. All you see is a little thinning of the cord, opposite cord. Oh, laser stands for laser assist surgeon enhances revenue. Okay. So this
they're losing it.
So this is what I was talking about. However, we are not lucky to land up with early cases. You have a late case, as you can see here. I think the light is going on. The floor and the mandible was involved. The entire middle third mandible was excised. You can see the post-op picture. You can hardly make out that he's been operated and his middle third mandible is removed. And the bone scan, you can see the fibula, the iliac crest graft which was taken and vascular anastomosis done. So what I'd like to draw attention that all these facilities are now going to be available at Acharya Nanesh Hospital. We have the team already, some of them working here. People from Bombay would come in when the appropriate cases are there. So these kind of facilities. But remember one thing, all this requires not just the surgeon skills or the medical oncologist, it requires a full gamut of people. You require intensivist, anesthetist, because one can't do without the other. And this whole team is what the idea of ACI collaborating with the hospital is, to get these facilities at your doorstep so that patients of New Bombay don't have to travel to Bombay, although not a long distance, but I think probably Atal Setu has solved a little bit of that problem, but otherwise it was a 2-3 hour job which you could take anyone anywhere else. Lots of strides made in radiation therapy as well today because of the specific targeted brachytherapy and radiation therapy for the early cancers. Remember one thing, a lot of our patients are getting elderly now. In India, no longer is 60 the ultimate age. We are looking into 70s, 80s as well. So treating this versus elderly group versus the younger group is a lot different because a lot of comorbidities are there with it. So there a lot of teamwork is required of a good general physician, a physiotherapist for rehabilitation, and that is the kind of setup that we need to promote everywhere. So what can we do today on World Cancer Day? I think it has been elaborated, but I'll just sum it up here. All of us at least get screening done once a year, especially for ladies after 40, pap smear, breast examination. In addition, exercise 30 minutes. I always hear the peculiar story of saying, no, I have exercised today, I walked in the hospital, then I went to that building, I went to that building. Exercise is not only physical, it is mental as well. So when you're doing the physical exercise, your mind should be on nothing else. Maybe you can listen to some music which you like, but basically it is mental, physical exercise. And that is what is required. Eat healthy, rich diet, fiber-rich food. Avoid tobacco, of course. Occasional alcohol is permitted as a grace from my side. Thank you. Yeah.
Can we have the lights?
Cost of CO2 laser and indications and contraindications.
So the cost of CO2 laser is like any surgical procedure. It will again depend on the tumor size. So like I said, this is what I showed you, the simpler ones, but there are complex ones where I've removed the base tongue, epiglottis, pyriform fossa, which takes 5 to 6 hours, just working under the microscope and doing the laser surgery. So it will all depend on that. But on an average, I can see if it's a vocal cord lesion, it would be between 1.5 and 2 lakhs, all found with the hospitalization, etc., with the machine charges and all. It would go marginally more if it is something which is more complex to about 3.5 lakhs. But that's the standard that would happen. The advantage of it is the patient is back home the next day, or if it's even a major surgery like I mentioned, within 5-6 days back home, swallowing, etc. Contraindications are when it goes outside the confines of anatypical boundaries. So if you have a tumor of the larynx, which has gone and involved the hyoid bone, or which has involved the thyroid cartilage, there are indications. I have been doing even for such cases and giving radiation, but ideally that is not a case for radiotherapy. That would require conventional surgery, where a laryngectomy has to be done. There is unfortunately permanent tracheostomy and a loss of voice. We have devices now, but it's not the same as a voice.
And this is included in insurance?
Yeah, very much so. Very much so.
What's about the peripheral lymph node, which are involved?
The neck nodes, they have to be treated on their own merit, of course. That's a regular neck dissection will have to be done.
That is not done with the
No, not with them. The laser is not, I mean, people have come to me with laser that, no, cut my neck with the laser and all. I said, look, it's like buying a 2.5-3 lakh computer and then saying 2 plus 2 is what? I said a calculator, 20 rupees mein milta hai. So it's a waste of resources, waste of thing. Basically the laser is, if you've been to a circus, you remember the sword swallowing? The circus people used to swallow. That's exactly what I do with the DN scope. Under anesthesia, it's rounded, it's not sharp, so I don't cut anyone's esophagus. But as the same procedure, you do it, and as you saw, this is a setup that you saw the vocal cord being cut, and through that you have to shoot the laser beam. It is a little time-consuming vis-a-vis the training program, because you are shooting at 400 millimeters. The laser beam with the joystick which is here and the target is somewhere here through a narrow 3 to 5 millimeter opening. So you got to be very precise in doing it. But practice on a joystick, like I said, on computer gaming, video games, and you'll get the mastery of it. Thank you.
Thank you.
Thank you everyone for the patient listening, and I think yes, it was a very interesting take, and sir is bringing some topic which is very I would say new to me, and we are definitely here to explore it. I want to just take a few minutes. We have Rahul Bajpai sir here with us, CEO Asian Cancer Institute. May I just please call him on stage to say a few words about our association, which will, I'm sure, also be helpful for the practitioners that we have here.
So no problem, leave it. I had a couple of slides to show you about Asian Cancer Institute. Good afternoon, everybody. Two things. One is, our organizers are very smart. First they said this is the last presentation, and they've put me as an element of surprise. So I'm the last barrier between the food and this talk. And Dr. Nikhil Varghese some time back opened the curtain and showed that the sun has started the journey towards west, so it's time for lunch. So we understand that everybody is hungry, but Asian Cancer Institute as a group is basically a group of surgeons primarily who have come together to form Asian Cancer Institute. Obviously what goes without saying is the expertise of all these surgeons put together. We are talking about a domain-based specific approach to solve cancer and cancer-related problems. Dr. Deepak Parekh, Dr. Sanjay Sharma just now talked about their domains, and we talked about head and neck, laser surgeries. Dr. Sanjay Sharma obviously CA esophagus. Dr. Ramakant Deshpande does thoracoscopic surgeries primarily for CA lungs, and Dr. Jagdish Kulkarni, who is a very well-known name for robotic surgery for uro, gynae, onco primarily. So these are the specialist surgeons who have dedicated themselves to Tata Memorial for many years. Out of their rich experience and expertise, they have come out to form Asian Cancer Institute. And now what we are trying to do is, as per the theme of the World Cancer Day, we are trying to be more accessible to people and do early diagnosis of cancer. And that is why we are putting up multiple hospitals in the in the geographies which has plenty of unmet need today. Like today, if you look at Asian Cancer Institute, we've got 3 hospitals in Bombay. We've got 50 beds in Kambala Hill. We've got 50 beds with Acharya Nanesh Hospital. We've got 100 beds in Indore, which are all operational. And we're putting another hospital in Virar on the northern side of Bombay. Plus, we've got Bhubaneswar, we've got Surat, we've got Pune, we've got multiple centers. This is for the country, specifically the geography which we are talking, and we are also putting footprints in various other geographies which are outside India, so that we can also take this expertise to major centers like in Nepal. Just now Dr. Deepak Parekh mentioned, we are going to Bangladesh, where we formed a company called Asian Cancer Institute BD, Bangladesh Private Limited, and we are putting up a greenfield project there. So this is what we are trying to do, small steps, but hopefully with their expertise we are going to reach out to the masses, get the diagnosis and education particularly of people like through these kind of campaigns and these kind of talks. So with that, I will just pass it back to Dr. Kshitija. I think it is a great journey with Asian Cancer Institute, because Nanesh Hospital is a group of very good people and team all put together. So thank you so much.
Thank you, sir. I'll take just a brief moment. I'm going to name my consultants who are here, and it's a big show of support for us. We have Dr. P. Singhania sitting right here. And may I please request sir to felicitate our speakers for today. So I'll just ask Sagar sir, Sagar Vaishnapan sir. Be felicitated by Piyush sir, please. I believe he's representative of Nanesh, so that is why. Can you just take the center, please? Yeah. Sir, please be seated. Because I have a lot of doctors here. Can I please have Prashant Pawar sir? I'm going to again consider him back in my team because we've already started work. Priya madam, she's a speaker, and I really enjoyed all the anecdotes from her. Madam, please, yeah. I would request Nikhil sir to come up, and he will request him to felicitate Deepak Parekh sir. May I please request, we also have Dr. Rahul Kumar Chavan in the audience, so sir, please come, and may I please request him to felicitate Dr. Sanjay Sharma sir. I would request Ajay sir to come forward, please. And he's just in the back end with all the doctors. I would please request Ajay sir to felicitate Bajpai sir. And he's representing the entire Nanesh team. It's a symbol of collaboration that we are having. I think we are all eagerly waiting for a vote of thanks, and then the food, me included. This is our major effort towards organizing an academic activity of such scale, and it has been a great morning right up to the afternoon. It is my honor to express a heartfelt vote of thanks on behalf of ACI Acharya Nanesh Hospital and our entire team. First and foremost, I would like to extend our gratitude to all our guests, our associate doctors who are present here in these numbers. These are our real community connects who grace this occasion with their presence. Your support means the world to us. Thank you for spending a valuable Sunday morning and afternoon with us. I want to express our deep appreciation towards our consulting doctors. I want to name them. I have Dr. P. Singhania sir here. We have Dr. Rajesh Patel here. We have Dr. Rahul Kumar Chavan sir here. Dr. Gauri Mike, I think he was one of the earliest ones to join. Dr. Prashant Pawar sir, we have Pranjal Gandhi here, she's a psycho-oncotherapist if I'm not wrong. So feel free to interact with all our doctors during the lunch time. Of course, we have Dr. Priya and other dignitaries who also were our guest speakers. Thanks a lot. We're joining hands with a very good institute to offer cancer services to the people in and around Navi Mumbai, and we need everybody's help to make this possible. Many thanks to our distinguished speakers for gracing the occasion and providing us with a treasure trove of knowledge. We are thankful to the HS Rinka Foundation Trust for showing their faith in us and their continued support towards the hospital. Last but not the least, I would like to thank our dedicated and I should say ever enthusiastic, I'm going to say over enthusiastic organizing team for the arrangements. Finally, as we close, I think we all should take this opportunity to thank our patients. Without their acceptance and support, Nanesh would never be what it is today. Thank you once again. You can proceed for lunch. Have a wonderful Sunday. Thank you.
We have I am President Dr. Sanjay Srivastav. Would like to have a feedback.
Yeah. So thank you very much for inviting me. बहुत ही अच्छा initiative है. All the speakers are very good और I think मैंने सबसे ज़्यादा questions पूछे हैं क्योंकि as a general practitioners हमारी बहुत छोटी queries होती हैं क्योंकि हमारा सबसे ज़्यादा direct interaction patients के साथ होता है. So thank you very much.
Thank you, we can break for lunch and general interactions. Thank you. We will also request some photographs to be done, which we always forget. If everyone could please gather for some photographs.
Thank you for coming.
Yes.